Welcome to this channel made for me again, and in this video we will learn about the chest x-ray. So before going to the abnormality, uh, we will first learn about the normal chest x-ray. So this is the say normal chest x-ray. In this, we have to know that the different densities of like ear, fat, blood vessels, and then bone metals. How do they appear in chest X-ray? So higher densities to lower densities, higher to lower. So the object with higher densities like metal, bone, and then decreasing to like water, fat, gas. These are the five substances uh, which appear different in the different chest X-ray. So this the higher one, like metal, this metal one will appear totally white. It will appear totally white, and then this bone will appear a slight transparent, not transparent, but it is little less white than metal one. It is less white. It is less white than metal, and then in the decreasing order, this gas will appear finally totally black. Okay, now we have to know that what are the things which are gas in the chest X-ray. So the gas will be air in lungs, and the fat will be like the fat layer in the soft tissues. Fat layer in soft tissues, and this water will be it can be same density as of heart. The heart also appear as the same density as of heart, same density as heart, and also blood vessels. And if water will be collected in the pleural space, then it will also appear at uh, this same density as the heart and blood vessels. Now bone means these are the most dense tissues, and finally this metal will be like foreign bodies. So these are the five substance which will appear different in the chest X-ray. So now let's see in the chest X-ray. So at first there are no metal. If metal will be present, metal will be present basically on the this either esophagus or trachea. If any substance is ingested, metallic substance, then it will appear totally white. And then bone. These are the bone. These are the bones which are appearing white. These are the vertebrae. These are the vertebrae. Okay, and then water. Uh, uh, this water density of water will appear similarly as that of heart densities, and the fat. Uh, these are the subcutaneous fat. These are the subcutaneous fats, and then this black one areas are the totally gases. So these are the five substances which we have to know. Now let's start with the interpretation of the chest X-ray. So interpretation. So before doing interpretation, okay, we have to know about the patient details, and then we have to know about that the chest X-ray is either PA view or AB view or lateral decubitus view. Okay, and then third is the we have to know that this X-ray is taken either on inspiration or expiration. We will learn in detail about that, inspiration or expiration. And then fourth, we have to know about the X-ray penetration. Either it is X-ray penetration. So either it is under penetrated or over penetrated. These are the four things which we have to know in detail. So in chest X-ray PA and AP view. Most commonly these chest X-ray PA views are taken, but when the patient cannot stand, or when patient is immobile, or when patient is unable to cooperate with the PA procedure, then we have to do chest AP view. Now for doing that, during doing the chest X-ray PA view, the X-ray film is in the front of the chest, and the X-ray beams are passed from the back of the body. So in case of chest X-ray AP view, the X-ray beams are passed from the front of the chest, and the X-ray films is placed in the back of the body. So during doing the chest X-ray PA view, when rays are passed from the back, the structures which are in the back are visible more clearly. But in case of chest X-ray PA view, the beams are passed from the front side of the chest, so the structures in the back, they are visible less clearly. And when beams are passed from the front, in the front there is a heart, so the heart is magnified. So in case of, now I will write the difference between the chest X-ray PA and AP view. In case of PA view, we can see that these are the scapulas. Scapulas are on the periphery, but in case of AP view, the scapulas are seen over the lungs field. They are seen over the lung fields. The first point is that scapula, they are seen in periphery, and in case of AP view, the scapula is seen over the lung fields. We can see that if this is the apex of the lung fields, then the clavicles are projecting over the lung fields, and it is tilted. But in case of AP view, we can see that if this is the apex, the clavicles are above the apex of lung fields. Okay, the clavicles are above the apex of lung fields, and they are somewhat straight, they are not tilted. So we can write that in case of PA view, the clavicle are slightly tilted. They are slightly tilted, and they project over long field. But in case of AP view, it is somewhat straight. Clavicle is somewhat straight, and it lies above apex of long fields. So these are the 2 points. Now one again, in case of PA view, we can see that the heart is not magnified. The side of heart is not magnified. But in case of AP view, we can see that the side of heart is magnified. So in PA view, heart is not magnified. And in case of AP view, we can see that heart is magnified. And in this picture, we can see clearly that the clavicles are somewhat, they are tilted, and in this they are straight, and the apex of lung field, they project over the lung field, and in this case they project apex of the lung fields. 2 points. And in third is the heart is not magnified well, and in this AP view, the heart is magnified. These are the 3 points. Now on the 4th points, in this PA view, we can count the anterior and posterior ribs. So I will make you sure that, like, we have to count, like, this is the first rib, second, third, fourth, fifth, sixth. These are the anterior ribs, and this is 1, 2, 3, 4, 5, 6, 7, 8, 9. This is the 10. So in case of PA view, we can see that we can see 6 anterior ribs and 10 posterior ribs. And if there are more than 6 anterior ribs and more than 10 posterior ribs, then we assume the picture of picture of PA view is hyperinflated. hyperinflated. We have to normally see 6 anterior ribs and 10 posterior ribs. If there are more than 6 anterior ribs and more than 10 posterior ribs, then the long field is inflated. And this is the third view, which is lateral decubitus view. Lateral decubitus view. Actually, it is taken when we have to know about the effusion. If the effusion is not clearly distinct on the chest X-ray AP and PA view, then we take the lateral decubitus position. So during this position, what happens is that if there is some amount of fluid, if there is some little amount of fluid, then they get collected. And we can also see the less amount of fluids collected in the chest X-ray. So usually they are taken during to know about the pleural effusion. To know about pleural effusion, if it is not visible, on PA view. So these are the three views which we do to take the chest X-ray. Now let's talk about the inspiration and expiration. Now we will know about the inspiration and the X-ray at expiration. So in inspiration, what happens is that at full inspiration, if the patient is taking deep inhalation, at full inspiration, this diaphragm, what happens is that this diaphragm is absorbed 8th to 10th rib, 8th to 10th rib posteriorly, and 6th rib to 6th rib anteriorly. Here we can see that this X-ray is taken. This X-ray is taken at full inspiration. So here what happens is that 1, 2, 3, 4, 5, 6. So this diaphragm is at the level of at around 6th vertebra anteriorly. And if you count the posterior ribs, then 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, around 10. So posteriorly around at 10th rib and anteriorly at around 6th rib. The diaphragm is positioned at this 6th and 10th rib. So this X-ray is taken at inspiration. Now let's talk about the penetration. So in a normal penetration X-ray, what we see is that this is the side of the heart, and beneath the heart shadow the vertebra should be visible. If beneath the heart shadow vertebra is visible, and the bronchovascular markings, these are the bronchovascular markings. These bronchovascular markings are also visible behind the heart, like we can see this bronchi. We can see if this is the side of heart, then we can see this is the bronchi which is visible, and these are the bronchovascular markings. We can see lots of bronchovascular markings which are visible. So if the thoracic vertebra is visible beneath the heart shadow and bronchovascular markings are seen beneath the heart shadow, then there is a good penetration. In case of underexposure and overexposure X-ray, we can see that on underexposure the intervertebral discs are not clearly seen. So in underexposed, underpenetrated, intervertebral discs are not visible, but in overexposed we can see that these are the intervertebral discs which we can see. So in underexposed, underpenetrated, intervertebral discs are not seen in the film, but in overpenetrated X-ray intervertebral discs are clearly visible. And in case of overpenetrated also, we can see the lung is more black out. Here you can see that the lung is more white out, and the shadow of heart is totally like the shadow of the dense metal, and here the shadow is decreased. So in this way we can differentiate between the underexposure and overexposure. I have made a mnemonic like A B C D E F G H I. A for airway. We will first study about airway. then B for bone, and then C for cardia, and then D for diaphragm, then E for any effusions, and F for field, which long fields, then G for gastric bubble, and S for hyla, and I for impression. So we'll if anyone asks us to read the X-ray, then we will read from ABCDEF. Okay, now let's first start with airway. So in airway we will see the trachea. Airway starts from this trachea. So we will look that is the trachea is deviated or not. First point, trachea is deviated or not. Then we will see the bronchus. These are the bronchus. Okay, we will see the bronchus, and in between that there is the carina where they are getting divided. Okay, so in trachea, in airway, we will study about trachea, either the trachea is in central position or not, and either trachea is deviated or not, or if there is any foreign body in the trachea or not. We will look that. Okay, now B for bone. So in bone we will start from this clavicle. Is there any fracture in the clavicle? Then is there any fracture in the scapula, or is there any dislocation in the scapula? Then we will see the ribs. Is there any fracture of the ribs? Is there any flail chest? Or then we will look this intervertebral disc. Then we will look the vertebra. Okay, in this way the bone will be studied. And you may be assuming that these are the pleural effusions. They are the white shadows in the at the costophrenic junction. So this may be looking like a pleural effusion, but this is not a pleural effusion. This is the soft tissue shadow of the breast. So this patient is the female patient. So this is the breast shadow. Okay, this is not an effusion. Now we will learn about the cardia. In case of cardia, we will first what will we do that we will take a midpoint line from the vertebra. Okay, this is the midpoint line from the vertebra. Then we will take the maximum distance from the at the left side and at the right side. Okay, so the maximum distance is here, and in the left side the maximum distance is this. Okay, so we will assume that this is A and this is B. Now we will take the maximum thorax diameter. So this is the maximum thorax diameter. Okay, so we will assume this as C. Now what we will do is that we will add this distance with, and we will compare with this. So A plus, so what will that, A plus B divided by C. This is the cardiac ratio and this is the thoracic ratio. Okay, so we calculate the CT ratio, cardiothoracic ratio. If the CT ratio is more than 50%, then the heart shadow is enlarged. Then heart shadow is enlarged. Heart shadow enlarged, which means there is cardiomegaly. Okay, and normally what is that, the CT ratio is less than 50. Normally is the CT ratio is less than 50%. Okay, now we will see the diaphragm, this diaphragm. So here we can see two humps. One is the right hump, another is the left hump, and right hump is around 3 centimeter. It should not be and it should not be more than 3 centimeter above the left hump. Okay, one is that, and both humps should be clearly visible. Then we will see the effusion. So in effusion what we see is that we see the cardiophrenic angle and the costophrenic angle. Okay, we see this cardiophrenic angle and costophrenic angle. We can see that this is very sharp and acute. Okay, if any fluid collection will be in this region, then it will be blunt. So if there is effusion, the costophrenic angle will be blunt. This is the costophrenic angle, and this is the cardiophrenic angle. Okay, this is the cardiophrenic angle. If there is any blunting in the cardiophrenic angle, then there can be pericardial effusion, and if there will be blunting in the costophrenic angle, there will be pleural effusion. So these are the two effusion which we see in chest X-ray. Now we will study about the zones. In case of while studying about the long field, now we will study the long field. In long field, first we will study the zones. So there are three zones. There are three zones. Three zones. The first zone is that we count the rib, like first rib, second rib, okay, then third rib and fourth rib. From the second rib, if this is the second rib, then we draw a straight line parallel to the this second rib, okay, second rib, and again this is the third, this is the fourth, and we again draw a line parallel to the fourth rib. This is the second line. Okay, now the zone which is above the second rib, this is the zone 1, and the zone which is between the second and fourth rib, anterior ribs, not posterior ribs, this is the zone 2. Okay, and the zone and the which is area which is below the fourth rib, this is the zone 3. So we can clearly see that zone 1, zone 2 and zone 3. So from at this side, this is the first rib, second rib. So second rib is like this, we are drawing this. So this area is zone 1, then first, second, third, fourth rib is this. So this area, this one is zone 1, zone 2 and this one is the zone 3. Now we are clear about the different zones. Now we will see the interstitial markings. If there will be any mass, then there can be infiltrates. Okay, there can be any infiltrates. Of if there is any mass, there can be the shadow of the mass. And here we can see the bronchovascular markings. These all are the bronchovascular markings. In case of bronchial asthma, these bronchovascular markings will get increased, but in case of like flail chest or this pneumothorax, whole lungs will appear as hyperlucence. There will be no any bronchovascular markings in case of this pneumothorax, tension pneumothorax. Okay, now G for gastric bubble. We can see clearly on the left side of the diaphragm. Below the left side there is one gastric bubble. This one is the normal, but if there will be any gastric, if there is any bubble or hyperlucency beneath the right side of the diaphragm, and if it is in concentric shape, then it will be gas under diaphragm. This will be gas under diaphragm, that is pneumoperitoneum. But if it is on the left side below the diaphragm, single, and then it will be gastric bubble. It will not be the gas under diaphragm because it is normally present. And in the last we will see this, the hilum region. We will see the hilum region. Okay, so in hilum region we can see that this is the aortic knuckle. Okay, and these all are the pulmonary vessels. These all are the pulmonary vessels. We can see the shadow. So we will see aortic knuckle, pulmonary vessels, and here we can easily see that there is a mass. Okay, so all these structures we will see from A to I, A to H. We will see. So I will complete this last I. So if someone will give me to read this chest X-ray, then what I will explain, please listen very carefully. So I will explain like this is the plain X-ray chest. This is not a contrast. Okay, so this is the plain X-ray chest PA view. This is the, I will write, this is the plain X-ray. This is the plain X-ray chest, which view? PA view, which is taken on erect position, and if date is mentioned taken on this date, and if the details of the patient is mentioned, then of a person this, and the exposure is good. I have explained about the exposure, under exposure or poor exposure, and it is the good exposure. Exposure is good. I can clearly see the vertebra under the under the this under this heart, and bronchovascular markings also can be seen under the heart. So the exposure is good. And now we explain from the first airway. The trachea is normal, it is in the center, there is no any foreign body in the trachea. The bones looks normal, there is no any fracture, and the cardiothoracic ratio is normal, so the heart is not enlarged. And I can see the diaphragm. The right hump is around 2 centimeter above the left hump, and it is due to the liver. And the costophrenic angle and the cardiophrenic angle, and cardiophrenic angle is sharp and acute, so there is no fluid, there is no any fluid or no any pleural or pericardial effusion. And the lung field appears normal, the bronchovascular markings can be seen, there is no any mass, no any infiltration, and there is a gastric bubble present on the left side of the hump of the diaphragm, which is the gastric bubble. And the hilary structures can be appreciated, like pulmonary vessels can be appreciated, aortic knuckle can be appreciated. So my provisional diagnosis is this is the normal chest X-ray. So in this way we have to explain. Okay, if there is any abnormality, then after this explanation we will go to the abnormality. Like if there is hyperinflation of the chest, then we will explain that the anterior and the more than 6 anterior ribs are visible and more than 10 posterior ribs are visible, so the lung is hyperinflated. And if it is a case of the tension pneumothorax, then we will explain that I can see there is no bronchovascular marking present on the right side of the chest. We have to mention the chest side of the chest, so there is no bronchovascular markings present on the right side of the chest, and the pleural line or visceral line is present on the right side. So I can so my provisional diagnosis is pneumothorax. Okay, in this way we have to explain. Now on the second video we will learn the different types of chest X-ray which are abnormal. Okay, so please continue to your next video. Thank you.